Good afternoon, everybody, and thank you so much for inviting me today to discuss the FlowTriever system for the treatment of acute PE. I'm sorry I couldn't be there in person, but I am very grateful that I was able to record this lecture for you. I'm just going to shut off my video and get started. So here are my disclosures. Now, the FlowTriever system is a large bore suction thrombectomy device that comes with a aspiration guide catheter in three different sizes, 16, 20, and 24 French. There's also a 60 cc large bore syringe that attaches to the sidearm of the aspiration guide catheter to aspirate thrombus. The system comes with these nitinol discs. This is a first generation FlowTriever disc, and then this is the newer generation FlowTriever disc. What this does, it allows the operator to engage the thrombus, liberate it from the vessel wall, and actually guide the thrombus into the guide catheter. In 2021, the FlowSaver device came out on the market, and this is a 40 micron filtration system that allows one to separate the thrombus from the blood and then re-administer the blood back into the patient to decrease blood loss during suction thrombectomy. Just going through the literature, the FLAIR trial was the first trial published looking at safety and efficacy of the FlowTriever device for treatment of intermediate risk PE. Looking at the safety results, 3.8% of patients experienced a major adverse events. These were procedure related and not device related. This included one major bleeding event, which resulted in pulmonary hemorrhage due to reperfusion requiring a lower lobectomy. Looking at efficacy, they reported a significant decrease in RV-LV ratio of 25.1% following treatment, and also for the patients who presented with pulmonary hypertension prior to the procedure, they reported a significant reduction in pulmonary artery pressures post-thrombectomy. Now, the FLAIR registry just published its results of 800 patients enrolled at 50 clinical sites in the United States between 2018 and 2021. This was a prospective, multicenter, single-arm study looking at safety and efficacy in a large real-world population for treatment of both intermediate and high-risk PE. The primary safety endpoints included major adverse events, and secondary endpoints included hemodynamic and clinical improvements, as well as length of stay. As far as immediate hemodynamic response, on the table, the FLASH registry reported a significant decrease in mean pulmonary artery pressure, as you can see here, and then also a significant improvement in cardiac index on the table in about 26% of patients who presented with a baseline cardiac index less than 2. Looking at acute clinical outcomes, the FLASH registry also reported a significant decrease in heart rate on the table and also at 48 hours. And then about 87% of patients had improvement in supplemental O2 status at 48 hours. So prior to the procedure, about 10.5% of patients were on room air. And then following the procedure at 48 hours, this improved to 71.2%. Echo assessments showed a significant decrease in RV-LV ratio at 48 hours and then at the latest follow-up. It also showed a significant decrease in right ventricular systolic pressure and significant improvement in right ventricular function. The FLASH registry also looked at dyspnea and quality of life measures. It demonstrated a significant improvement in dyspnea scores, as you can see here. And then also, as far as the pulmonary embolism quality of life scores, this also significantly improved. Safety and mortality outcomes included a 1.8% major adverse event, and 0 were related to the device itself. 1.4% were major bleeds, and 0.4% were intraprocedural adverse events, which included 2 clinical deteriorations and 1 cardiac injury, which was newly diagnosed tricuspid regurg on an echo about 2 months post-treatment, and this was uncertain whether it was related to the study device. As far as all-cause mortality, it was low at 0.3% at 48 hours, 0.8% at 30 days, and 5% at 6 months. Looking at hospital resources, inpatient and then again at 30 days, the median hospital stay post-procedure was 3 days. About 63% of patients had no overnight ICU stay post-procedure. And for those patients who did require an ICU stay, the median ICU stay was 1 day. All-cause readmissions at 30 days was only 6.2%, and 1.4% of these readmissions were related to the PE treatment. Looking at FLASH in perspective and 30-day all-cause mortality compared to the PERT database and this very large meta-analysis looking at catheter-directed thrombolysis versus anticoagulation, the FLASH registry had showed a lower all-cause mortality. Of course, these are different patient populations, and it's hard to compare them head-to-head, and that's why we're looking forward to randomized controlled trials. However, it does show a lower all-cause mortality at 30 days. In addition, the 30-day readmission compared to the PERT database was also 6.2% for the FLASH registry compared to 24.4% for the PERT database. The FlowSaver device was introduced into the FLASH registry late in the game because it was available in 2021. So about 82 patients, or 10.3% of patients, the FlowSaver device was utilized for the suction thrombectomy procedures. And you can see the blood loss was 100 cc's. The median blood loss was 100 cc's compared to 250 cc's when the FlowSaver device was not used. And again, this is a filtration system designed to filter aspirated thrombus from free-flowing blood, and then you can return the blood to the patient via the cytosol or the sheath. So this is a game changer and really does decrease intraprocedural blood loss when utilized. And this is just a video that shows it. This is a syringe that has blood clot and free-flowing blood. It goes through the filtration system, and this syringe here is the blood that can be returned to the patient. So the one weakness of the FLASH registry was that it allowed patients to be enrolled after the procedure, so patients could be consented and enrolled afterwards. And this could have introduced some bias into the results that I just presented. But fortunately, in my experience, I've had no major events, adverse events with the FlowTriever system, but it's very important because it's a large bore suction thrombectomy device that technique is very meticulous. So I'm going to just give you a few tips, and some of them are very obvious, such as using ultrasound guidance for venous access. I typically use a 21 gauge needle and single wall technique. You should traverse the heart with either a pigtail, well-formed pigtail, such as these, or a balloon-tipped catheter with the balloon inflated to prevent going through the chorda tendineae. As you can see here, these are very delicate structures. You want to avoid cardiac injury when you're advancing the large bore suction thrombectomy device. I also use a Amplatz super stiff wire 035 with a 1 centimeter floppy tip to give me the support that is needed to advance these larger catheters through the pulmonary vasculature. And you also do not want to advance the aspiration guide catheter too distally to prevent vascular injury. And I just listed the outer diameters of the T16, 20, and 24. And then also, if the patient develops pain or feels discomfort, don't keep advancing the catheter, just stop, and then maybe just check to see if you've gone through the chorda tendineae. This is a patient who had a suction thrombectomy procedure at an outside hospital with a different system. The patient developed hemoptysis. They terminated the procedure and transferred the patient to Jefferson. You see here on the arteriogram of the left pulmonary artery, there is a sizable pseudoaneurysm that required coronal embolization. So if a patient develops hemoptysis during a suction thrombectomy procedure, it's very important not to terminate the procedure, but maintain wire access. And this way you can find the injury more easily. And also you can advance a balloon occlusion catheter over the wire to tampen down the bleed. You could also reverse anticoagulation if the bleed is not rectified with the balloon inflated for at least 10 minutes. You can position the patient with the bleeding side down, electively intubate the patient to protect the airway, embolize if possible, consult cardiothoracic surgery early, and also avoid treating patients with prior chest irradiation, evidence of CTEPH, and distal thrombus, because perforation is more likely in these conditions. This is a patient who presented with an intermediate high-risk PE. This is a CT. You can see a large amount of clot, especially on the right side. Patient underwent a pulmonary arteriogram, which you can see here. There's decreased perfusion to the right lung with multiple interluminal filling defects. The patient also had elevated pulmonary artery pressures at 54/32 millimeters of mercury. I placed a FlowTriever device in the right pulmonary artery, aspirated, and got no blood return. So I did it a couple times and still was unsuccessful in aspirating any thrombus. So I figured the clot was trapped in the aspiration guide catheter. So I exchanged out the aspiration guide catheter over a wire, and I injected contrast through the side arm of the sheath, which I could show you here. And this is the sheath, and this is the aspiration guide catheter. You can see that there is clot lodged in the tip of the catheter, but also extending into the inferior vena cava. So this is known as a lollipop clot, which has a very sweet name for something that does stress you out during the procedure. The most important thing is to maintain suction on the side arm of the aspiration guide catheter. You can also apply suction on the side arm of the sheath as well. And you can exchange the aspiration guide catheter over the wire and also the sheath if necessary. But always maintain wire access in the pulmonary artery in case you have to go ahead and chase the clot. In addition, the other option is you can prep a second access, such as the contralateral groin or the IJ, and place the FlowTriever disc cranial to the clot to protect the clot from embolizing centrally. And you can also use the FlowTriever disc to deliver the clot to the aspiration guide catheter. This is the same patient. This is what he looked at, liked pre-suction thrombectomy. And after we removed a significant amount of clot, you can see the angiogram, and I'll show you the movie, the digital subtractional angiogram. You can see marked improvement in the flow to the right lung with a significant decrease in clot burden. So in summary, the FlowTriever system is a safe and effective treatment for acute PE. The FLASH registry showed excellent results, on-table hemodynamic improvements, improvement in cardiac function, improvement in dyspnea and quality of life scores through 6-month follow-up. But again, it is very important to make sure you use meticulous technique when you're using these large bore suction thrombectomy devices to prevent cardiac or pulmonary vascular injury. And we are really looking forward to additional data using these suction thrombectomy devices. The FLAME registry hopefully will release their results of treatment of acute massive PE with the FlowTriever system. And I'm very excited about the PEERLESS study, which is ongoing. This is a randomized controlled trial comparing FlowTriever to catheter-directed thrombolysis. We are enrolling a total of 550 patients who will be randomized, and about 150 patients who have absolute contraindications to catheter-directed thrombolysis. They will be treated with the FlowTriever system alone. And then, of course, the PE trial by Dr. Sista is very exciting, and we'll look forward to that as well. This is a randomized control trial comparing anticoagulation and catheter-directed therapies, including both suction thrombectomy and catheter-directed thrombolysis. And this is going to include a total of 500 patients. So very excited to have more data to better help take care of our PE patients. So I thank you again for allowing me to record this lecture, and I really hope you enjoy the rest of the conference.